Okay, we are starting recording now. But yeah, these are our definitions of harm reduction. So let's jump into the principles of harm reduction. If you want, if there's any questions you have, throw them in the chat, or if you've seen other definitions of harm reduction and you want to share them, I'd love to see them in the chat as well. Cool. So the principles of harm reduction, these are kind of your guiding parts that define how we do harm reduction. All of these have come from the International Harm Reduction Coalition. That coalition also is one of the major contributors and founders of the International Harm Reduction Journal, which is where we find a lot of our information and evidence based around harm reduction. So a really good body. And also if you go onto the International Harm Reduction Coalition website, you will find a huge amount of really helpful resources for different regions across the world. If you want to look specifically at the continent or sub-Saharan Africa or West Africa, you can also find those divisions there. They do a fantastic report where they go into regional reports and that sort of thing. I highly recommend it. So our first principle of harm reduction is accepting drug use, legal or otherwise, as part of our society and choosing to minimize the harmful effects rather than condemning or ignoring drug use. So I'll take this apart a little bit because there's kind of two different sections to this principle. So the first being accepting that drug use is part of our society. I think we all know this. We know that the war on drugs and the prohibition of drugs has not been successful in, stopping drug use existing. And that's what we're saying here. We're accepting that drug use is part of our society, that suppressing it doesn't help. And then a nice little note within this is illegal or otherwise. So just take a think about what sort of legal forms of drug use. We're talking about legal drug use as well as illegal drug use. There's two different, though they are different, they can be very similar in pattern. And then the second part of this principle is choosing to minimize the harmful effects rather than condemning or ignoring drug use. And that's one of the kind of cornerstones of harm reduction for you. So what we're saying here is rather than ignoring drug use or saying it's a bad thing or whatever, we're choosing to do anything we can to minimize the harmful effects, the dangers, or the risks involved with drug use. That's what we're choosing to do instead of condemning or ignoring drug use. So that's your first principle. I am going to bring us on to our first question to reflect on, which is, how have you seen drug use in your community? So this is just a question for you to think on personally, and maybe you can put some of your thoughts in the chat there as well. But think about, how have you seen drug use in your community? Has it always been legal or has it been illegal? And also, have you seen times that it has been, where minimizing the harmful effects would have been more effective than condemning the drug use? But yeah, that's just like a first little thought there, first reflection question. So the principles of harm reduction, the second one is understanding that drug use is complicated, and that it includes a wide range of behaviors from high usage to total abstinence, and recognizing that some ways of using drugs are safer than others. So there's a lot in this principle, but let's go through it. So we're understanding that drug use is complicated, that people use drugs differently, and they go from not using drugs at all, and like the series of behaviors that can exist can be using drugs really often all the time, and using really large amounts, or it could be so many different patterns of drug use exist. We're recognizing that it's complicated. It's not a simple cut and clear one size fits all. It is complicated. But what we're saying as well is that we recognize that we know that some ways of using drugs are in fact safer than others. And that's important for us to know, and for other people to know. So that's your second principle of harm reduction. And we'll go into your question to reflect on for this one is, have you considered the idea that drugs could be used safely? That's just like a question to think about. I think a helpful thing to start thinking about in this reflection question is the fact that some drugs are legal and some are illegal. So that's a nice way for you to begin thinking about that idea of whether or not drugs can be used safely. And yeah, feel free to put stuff in the chat if you have any thoughts about that you want to share. But that's your second principle of harm reduction. Let's go into the third. So the third principle is harm reduction considers the quality of individual and community life and well-being. Considers quality of individual and community life and well-being, not necessarily stopping drug use as a criteria for success. So what are we saying here? What we're saying here is that when we're defining success in harm reduction, when we are talking about did we do well when we did harm reduction, right? We're looking at, did we maximize the quality of life and the well-being of the individual who's using drugs and of the community that surrounds that individual. So that is like our utmost and most important aspect. That's what we're trying to do here. We're trying to, ensure that quality of life and well-being of the community and the individual is at as best as it can be. And we're recognizing that that does not always include stopping drug use. Sometimes it does. For some people, abstinence does work, but not necessarily for everyone. And we're certainly not making stopping drug use the benchmark for doing successful harm reduction. The idea is maximizing individual life and well-being and community life and well-being. So that's your third principle. I'll give you another reflection question for you to think about, and you can share your thoughts in the chat. So the question here is, how are you defining success in harm reduction or advocacy even? And consider the idea of functional drug use. Have you seen this before or experienced this before? Maybe you don't want to share that, but like maybe think about that personally a little bit. Yeah, that's your reflection to your question to reflect on for this principle. I'm just going to check the chat quickly here in case we got anything. Just introductions. Lovely. All right. The fourth principle for harm reduction is harm reduction calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing harm. This one's pretty straightforward, but the two aspects of this that I would suggest that you think about a little bit more and look at is what do we mean by non-judgmental and non-coercive? So coercive is talking about when you are persuading or forcing or pushing anyone to use a service, in this context, to use services for people who use drugs or use resources in a specific way. I'm sure many of you know that there's a lot of forced treatment that happens on the continent, and forced treatment is inherently negative and not particularly successful. So when we're talking about harm reduction, we're calling for non-judgmental, non-coercive provision of services and resources to people who use drugs. Also, a quick note, you'll have noticed a little bit of a trend throughout the principles here, where we're talking about not only people who use drugs, but the communities in which they live in. This is a really important aspect because harm reduction doesn't always have to be looks beyond just the person using drugs and also towards the communities that can help them reduce harm as well, because we all live in communities and this is important. But just a nice thing to remember in your mind, for the most part, harm reduction does focus on the needs of people who use drugs, but considering as well the people who are surrounding that person are also very important and also can be quite helpful in these situations. So that's another little aspect for you guys. So that's your fourth principle of harm reduction. I'll give you your question for reflection. Think on the idea of non-coercive provision of services and what that actually means in the practical sense. So yeah, I would say just take a look into this idea of non-coercive provision of services and what that means in practice. So yeah, and also I'll mention as well, like as an example of a service, if that's something that you're wondering about, you'll see like needle exchange or syringe exchange. Those would be considered a service, a harm reduction service. That's just an example to get you going. But these services can come in lots of different shapes and sizes and serve different types of drug use and different types of people. So important to remember that while you're going along. So our fifth principle of harm reduction is ensuring that people who use drugs and those with a history of drug use have their voice centered in the creation of programs and policies designed to serve them. So this is really important. The whole idea behind this is that we are making sure that people who use drugs and people who have used drugs, the people who have the most legitimate experience in relation to drug use and drugs in general, that they are at the very center of the creation of programs and policies. And the reason for this is, firstly, nobody knows better. And secondly, as a highly stigmatized population, it is extremely important that they get the necessary protections when it comes to programs and policies. So yeah, it's extremely important that people who use drugs are at the very center and they are the people driving this and that they are very included in it, because if you want a successful program, getting the people with the best experience about about the population you're trying to serve is key. And historically, people who use drugs have not been included in the creation of like services or policies surrounding drug use. And that is one of the major explanations as to why those policies continue to fail us. So yeah, that's your fifth principle. I have no question for this section, but let's keep going. The sixth principle is that harm reduction emphasizes that people who use drugs themselves are the best way of reducing the harms of their drug use, and seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. So this one is a bit of a mouthful, and like I'm going to go through what that actually means altogether. But okay, let's take this like kind of piece by piece. Let's start with the first thing. That people who use drugs are the best way of reducing harms of their drug use. So you might ask why people who use drugs are the best way of reducing their harms. It's because they know how they use drugs, what type of drugs they're using, and they understand the context better than anyone else. So of course they are the best way of reducing the harms of their own personal drug use. So when we go beyond the individual themselves reducing their own harm, we're talking about this second part here where we talk about sharing information and people who use drugs supporting each other in strategies which meet their actual conditions of use. The reason why we call this peer-to-peer, right? So people who have very similar experiences will trust each other more. And then when you're talking about a really stigmatized population, like people who use drugs, they're very unlikely to trust authority because they have been hurt by authority or pushed out they've suffered a huge amount by the way authority and like maybe the wider community has treated them due to their drug use. So they're very unlikely to actually trust or believe those people. That's why peer-to-peer is extremely important. And also the additional factor that when people who use the same types of drugs in the same context are talking to each other, they have far better and far more complete knowledge of what type of drug use we're talking about, and this like term, the conditions of use, the environment they're using in, how they use, and all of this sort of thing, all of the different aspects that come together to make like the way people use drugs. Other people who use drugs similarly will have a better knowledge of it. So that's why these people will trust each other before they'll trust other people. So that's why they would be one of the most effective people to share information, because the information coming from another person who uses drugs is far more valuable than the information coming from perhaps like a school teacher, because they might not believe that person. And we also know historically drug education has told a huge amount of lies, or has told, you know, very exaggerated information or inaccurate information that would give you a natural distrust of the education you're getting about drugs. So that's why this peer-to-peer education, this sharing of information from person who used drugs to other people who use drugs in similar ways is extremely important, but also hugely effective. If you're interested in learning more about peer-to-peer education, we have our own peer-to-peer education program called Just Say No, spelled K-N-O-W, to know as in to have knowledge. Yeah, it's a really great program. And also if you ever want to like find more resources or evidence around why peer-to-peer education is really effective, let me know or let Maranflu know, and we can send you in the direction of more resources. But yeah, this is our 6th principle. I'll see if I have a question on this one. So yeah, my question for reflecting on is just think about the idea of trust for stigmatized communities and how that can affect their relationships and communication patterns. Really important to think about that, because the better you understand that, the more you can get it, how really stigmatized people are affected. Let's go into, I'm just going to check the chat quickly in case there's anything, and we'll go into the 7th principle. All right. So the 7th principle of harm reduction is that harm reduction recognizes the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities we recognize that all of these things affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. So what we're saying here is that all of these things that cause social inequalities or mental stress on an individual, so I'm sure, as you know, poverty, class, racism, past trauma, sex-based discrimination, all this sort of thing can really affect, you know, the mental state of an individual, the amount of stress somebody is facing, and a series of other things that might lead them to be more vulnerable to drug-related harm. So what we're saying is we are recognizing that all of these kind of stigmatizing things will affect somebody's ability or capacity to deal with drug-related harm. And it's important that we're cognizant of that while we're doing harm reduction, because understanding the context of the people you're talking to is extremely important. We need to understand, like, you know, hostility, you know, mental health, all of these different aspects, and all of these things that are listed here, plus a large amount more, can add to those. And it makes people less, you know, the worse off people's mental health is, the harder it is to deal with your own self-care and that sort of thing. Those are kind of generalizations, but you'll see what I mean. Some important things to note is, you know, we all know that the war on drugs is rooted in racism. When it was born in the US, it was racist, and it was targeted at people of color in America. And, you know, it continues to focus on marginalized communities. So though it might not always be racism, it might be targeting at stuff like, you know, specifically at women might suffer more in these conditions. Different ethnic groups might be targeted more. and all of this sort of thing, which I'm sure many of you are aware of. But yeah, important to stay cognizant of these things while you're doing harm reduction, and not just to be aware of them, to be sensitive to some of the things that the people you are giving harm reduction to might be facing. So the question to reflect on, and this might be really, really helpful for you to begin reflecting on, and I think is one of the most helpful questions in this thing, is what factors have you seen affect people who use drugs in your community, your region, or your country? And do you think these factors affect mental health by any chance? Just as a reminder to anyone who joined in the meantime, what we're doing here is I'm going to explain a principle. We have reflection questions, which I suggest either you answer maybe in the chat or you just answer personally on your own. Also, at the end of this, I will send all of the questions in for you to maybe go back and reflect on later as well. But yeah, this is, so what I'm suggesting here is that you think about, is there certain communities that are more affected by the war on drugs than others in your community? Do you see people who use drugs being labeled in very specific ways? Just to be cognizant of stigma and how oftentimes certain groups are pushed into different places. So yeah, take a look into that one. We're coming on to the last principle now, and then we will take a few seconds for questions and anything like that. And after that, we'll go into our speakers. So our last principle is that harm reduction does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. So what we're saying here is, though harm reduction can be really effective, and we know that to be true, it's extremely important for us to be aware of the real and tragic harm. Many people have, died from drug-related death. Many people have suffered serious illness, and there's a huge amount of danger and really a lot of risk involved in this situation. So it's really helpful to make sure that you are always remembering that we are not, sorry, 2 seconds. So it's really important not to ignore that. It's really important to be aware of that and keep that in mind while you're doing it. This is a dangerous space. This is, as long as drugs are illegal and not regulated and we can't use them safely, there is always going to be these risks, and it's important that we don't ignore that. So that is our final principle of harm reduction. The last question I have for you to reflect on is, have you or people you know experienced harm or danger as a result of illicit drug use? Do you think these principles and harm reduction might have helped in those situations? So that is your last reflection question. So yeah, that's the principles of harm reduction. Just as like a last little slide I've added in here before we go into any questions is, this is just like a fact for you to just be aware of. So in 2018, there was an estimated 2.3 million people who inject drugs in sub-Saharan Africa. 546,000 of them were living with HIV. The reason I've included this here is that HIV and AIDS are completely preventable, and particularly through using harm reduction techniques to prevent bloodborne diseases spreading. This is something that, this is like a very clear space that harm reduction can be implemented in, and also so that you're aware that people who inject drugs particularly tend to be more stigmatized and also not receive as much services. They're also more highly prone to bloodborne diseases than other communities. So that's just an idea of you of like kind of to what level we're looking at this at and that sort of thing. Okay, so I am going to pause here for any questions. So if you have any questions, please feel free to put them in the chat, or you can also come off mute now and ask them if you have any questions. Williams, please, you can come off mute if you wish, or put it in the chat, whichever you prefer.
Róisín?
I'm getting you.
Hello. All right. Greetings to everyone. I'm Iweli Williams from SSDP Liberia. And Róisín, my question is just with the principle, like what we have observed, like we we have we have run a survey, and we look at, like, for example, like country like Liberia, maybe Ivory Coast, Guinea, and Sierra Leone. So we found out like harm reduction is something that is not like well understood on this side, because like we have seen people like taking it on a different route. Like, imagine that our drug law in Liberia is non-billable, something wherein that the LD is advocating for the law to not be like non-billable. So like we having to have people pushing non-billable laws, saying that like people who use drug, if being caught and should go to jail. Like in Liberia, like you cannot like take like needles and syringe to people. Like they will say like you are taking them. Like, so the thing is, like, my question is like my question has in harm reduction has to do with like, if you if a country is not accepting like you to take needle and syringes, or to create awareness that reduces risks, because we understand harm reduction reduces risks, which is like you're not stigmatized, like you said, non-judgmental. It's a human right based stuff that protect people who use the substances or people who are on substances. And series of interview with people who use substance, they want to go to good medication years to years. They want to have like the female users. They give birth in the ghettos, no proper care, trafficking come out, and all these things. So like in West Africa, we have a challenge. Like the harm reduction method is not working, and the drug policy is something like not the people pushing to make it non-billable, and they are not taking in reference of the human rights issues. Looking at the situation that we have a model of drug law in Africa, we have the West Africa drug law, and they have harm reduction spread. So how do we like community based engage this issue, engage this concept in a community of a drug users? Like I was just thinking, like contextually, I don't know if you really get my question, but that's how I was like, you know.
Yeah, I hear you. I will say I might not be the like perfect person to answer this question, and I'm going to suggest if we take a look at so the International Network of People Who Use Drugs have just released an absolutely fantastic series called the oral history of the movement of people who use drugs, and it takes a look at different regions across the world and where they started with harm reduction, where they started with advocacy for people who use drugs, and how that happened, like what happened in order for certain countries to be able to do this. And I think like taking some inspiration from that would be really, really helpful for like first steps, because you know the more I kind of learn about the West African situation around drugs, and particularly some of the more conservative countries, it sounds like what we need is advocacy, like because the governments are so adverse to it, and like it is so high risk to engage with it. We need to start like being out on the street and doing our thing. Now obviously it's a pandemic, so I'm not suggesting that you get close to people or anything like that, but maybe it might be an idea for us to like start a harm reduction working group or some sort of advocacy working group for West African countries, so that we can begin to tackle that issue and share experience. And then the second thing I would say is probably the most effective way to deal with this is working with as many allies as we can, or building coalition or something like that, in order for it to like for us to actually get to a place where change is happening. That's the best answer I have now. But what I would suggest as well is our speakers might be able to answer that question a little better as well. So maybe we'll have them have their piece as well, and they can give some feedback alongside that. Am I helping answering that question?
Yeah, it's better. It's better. It's better.
All right. Ooh, you raised your hand and I don't know how to call on you. Obayemi, if you would like to unmute, please do.
Yeah, thank you very much. I had a related question now, and I just wanted to say that it's going to be part of what will be included in my presentation. So maybe when I'm presenting, I'm planning to listen more so that these can be addressed. I've noted it down, and of course, it's in Liberia and I'm in Nigeria, so I believe we'll share a lot of things in common, and I'll be able to relate some field experiences from here that will be able to help with their mode of intervention in Liberia.
Yeah, that would be great. Yeah, I think actually we can probably, unless there's any more questions on the principles, if anyone has a question, please like raise your hand or put it in the chat now or unmute yourself and say it. But otherwise, we're going to move on into Obayemi's presentation, if that's okay.
Okay, can I go ahead now?
Yeah, please do. I have a slide there for you, but please go ahead.
Okay, thanks so much. I want to really appreciate your presentation first because the principles you actually took us down on have proven to be effective. And because of my presentation now, I want us to be thinking, I mean, the questions you asked, the personal questions you asked, I want participants now to be trying to like answer it from the real life experiences I'm going to be giving in the course of my presentation. So I'll call the title of this presentation the Introduction to Harm Reduction in Nigeria, and the successes, the challenges I've been able to experience so far. First, I would like to state the sample population that I'm working with, because the state I'm working in Nigeria presently is called Oyo State. It has, as of 2016, a population of approximately 7.8 million. And of this population, according to the KP census mission that was carried out in 2018, over 14,000 are found to be injecting drug users. So this raised the question as regards the number of them that may have health issues and health challenges, which my organization works in addressing. And we, at the international, I mean, at the national level, there have been meetings, there have been learning sessions, there have been foreign learnings too. For example, when the theme on harm reduction in Nigeria was set up, it's comprised of members of the parliament, people from the presidency, different organizations working on drug and human rights. Then we had Federal Ministry of Health and some others. They went on a learning session to Kenya, which has been an African country implementing needle and syringe programs and some forms of harm reduction programs, to learn how they've been able to do there, then to be able to come here and replicate the same thing. Though they had, when the delegate from Nigeria went, they had a little lesser population than we have in the country, which means that we have more work to do from here to project to the world to see how things work in sub-Saharan Africa. And of course, Nigeria, with a population of around 200 million, has a lot of international migration when it's talking of the West African sub-region, which makes them very prone to, which makes us as a country very prone to some infections that can be contracted via injecting drug use and some others. So the program we implement here in my state is divided into two sections. The first is the HTS section, while the second is the NSP. The HTS is HIV testing services, strictly for injecting drug users. It is an 18-month program in which we targeted reaching over 6,000 IDUs here in Oyo State. And of these 6,000 IDUs, IDUs, we targeted having as many HIV positive among them as possible to be referred to care. Then on the NSP, which is the needle and syringe program, we just started this year. It's the first of its kind in Nigeria. Started in June, and it involves needle and syringe exchange, strictly among drug users. Injecting drug users. So the mode of selection of staff is that those who will be working on the field are strictly injecting drug users. So this is in line with one of the principles that Róisín mentioned earlier. I think that's the number 6 principle in terms of supporting each other, because no one can understand a drug user like a drug user, and no one can understand an injecting drug user like an injecting drug user. So we believe that for us to be able to reach the group of people we intend reaching, we need to use people who engage in the same practice as them. So the recruitment process was having drug users, especially those domiciled at drug bunks. We have to pick some of them. We train them on things they will need to do on harm reduction generally. Then these are the same sort of people that now go to their own peers on the field to give them harm reduction information. So in the course of giving harm reduction information, first on the HIV testing project, the information they pass across is as regards behavioral change. That one is not about needle and syringe, just strictly behavioral change. They talk to them, ask them questions, try to know what their challenges are. Then they have to conduct HIV testing services for them. So in the process of conducting HIV testing, they get to know whether they experience STIs, so whether they have STIs, whether they are coughing, whether they should be referred for tuberculosis. Then they try to know whether they have some other infections, especially HIV. If they are discovered to be HIV positive, they will be referred for treatment in one of our supported facilities that is closest to them. Here, they are going to get free HIV treatment. They call it ART treatment. Then those who mention anything related to sexually transmitted infections too, they also refer to healthcare facilities closest to them that partners us, and here they get free services for this. Then on the needle and syringe programs, we train another set of people for that who have knowledge of how to safely inject, who have the knowledge of full knowledge of what harm reduction is all about, and who also are good at communicating with peers. So it is a peer-to-peer model. It's not going to be like a classroom session where someone is just going to be talking to a group of people. No. Each person trained by us for needle and syringe program is expected to reach a particular injecting drug user to assess needs. We first did needs assessment. After the needs assessment, during the needs assessment, the peer, our trained peer, will first know the kind of drug the particular IDU injects, then he uses. know how often he uses it. They know the type of needle and syringe he also uses. So after this needs assessment, the peer is going to come back to us and give us the breakdown of all this. We had a tool, a tracking tool for that. So the way the field staff is going to be reaching that particular drug user is going to be client specific. So assuming I'm a drug user now, and I've met someone and I say, okay, I inject heroin 2 times a week. I know that when my peer, when the person talking to me is coming to me, is going to be coming to me 2 times a week with at least a needle and syringe. Clean one, new one. Then he's going to ask for the previous one I've been using. So if I'm willing to give it out to him, fine. I give it out to him for him to safely dispose. But if not, he's still not going to deny me the opportunity of having that clean needle to be used. Then we were also able to train them on how to counsel for wounds, because some of them, in the course of injecting, they will have sustained wounds and injuries. So this set of people, we refer them to our partnered facilities for wound treatment too. And also those who may have TB, tuberculosis, who may be prone to tuberculosis among them, or STI or hepatitis among them, we refer them for all of this. So that is the structure of that, like the whole scope of how the our work here is done. Then on tools, since Nigeria is a very new country when it comes to harm reduction, both our clients and our staff are very new to tools being used in the field, such as the picker, tourniquet, cooker, even water for injection, because they are used to getting some of these things locally. So new ones, good ones are supplied to them so that they will be having access to clean and new tools to use in the course of injecting or drug use, thereby preventing harm that they may be prone to. And so far, in the last 15 months, of close to 5,000 IDUs we've targeted on the HIV testing program for them. We've been able to have over 140 who are HIV positive and have been successfully enrolled to care at a supported health facility to date. And every month we still have more. Then on the needle and syringe program, we were able to sample a 1,520 population, of which we are still doing HIV testing services for them too in the course of the whole needle and syringe program. And among them, we intend completing their testing by next month, which is December next year. And so far of the group tested, we've had over 30 who are HIV positive and who have also successfully been enrolled to care. And among them too, we've had those who've been referred for wound treatment, we've had those who've been referred for TB screening, who are screened for TB and referred for treatment. We've had those who have been referred for STI and some other services that we render. But one challenge we've had we've had series of challenges in the course of this project implementation, because in Nigeria, drug use is illegal. And law enforcement agents are always on the lookout for drug users. This makes it a very big challenge. Though the government partners us at the national level, but information usually does not stream down to the local level. For example, if those at the national level are organizing a stakeholder meeting with government officials and all those who may be involved in our intervention, it is the key officers that are invited. But in their different parastatals and ministries, we realize that they don't stream down information to those who we are going to meet on the field. So we've had cases of arrest because of our project implementation. We've had cases of arrest in the bongs on the field where we now have to start calling and trying to get our people billed. Then we realize that drug users do not trust the authorities and law enforcement agents. So even when they see us, when they see our trained injecting drug user peers come to them, the number one question they ask is, hope you are not working for the government to come and arrest us. Okay, you are not working for the law enforcement agents. So we usually have the challenge of allaying their fears and making them comfortable enough to be able to relate well with us and allow us to pass the harm reduction information we are passing across to them. We also had issues with inadequate facilities due to socioeconomic factors we have in Nigeria. For example, for a needle to be disposed safely, incinerator has to be used. But you'll be surprised that in a state of or province of like 7.8 million people, there is no functional incinerator to safely dispose used needles. So you can imagine the challenge we have when we retrieve needles from these people and have to dispose. We have to make sure we partner some with private firm to help with the disposal and incineration of these needles. Then prejudice and discrimination toward drug use, toward ID use is also another issue. And this most time makes them very aggressive towards whoever is coming to them. They have bonds, they have communities where they reside. So when you are new to that place, they are usually very hostile against you because they believe that you are already prejudiced against them. So they want to take it on you. And because of this, many of them belong to different fraternities and gangs, deadly ones. So if care is not taken, when we go to these places to give them harm reduction information or to provide services for them, at times our staff get attacked in the course of all this, probably on the way going or on the way back. Then we have the services rendered have very high cost implications. Nigeria as a well, it is claimed to have, the country is claimed to have the highest GDP in Africa. But when we talk of the per capita income of individuals, we realize that it's nothing to write home about because of the population. So to render services to people, for example, if I'm a drug user, if you want to come and render a free service to me, I may be forced to demand money from you first before I even allow you to render such service to me. Because I don't have a job, I'm discriminated against because I'm a drug user. Nobody wants to befriend me, nobody wants to see me. So it is the group of people that are willing to do anything with me that have to ask for money. So apart from the services we render, such as giving them needles, giving them commodities, even condoms to use, they still demand for money. So this makes our work very, make the cost indication of our work very high because we have to spend a lot. Then distance too is another challenge. Our facility, the health facilities partnered by us are not located in the same place, though they are located in different places. But drug users, because of the nature of activity they engage in and the hostility of the government and people towards them, they tend to live in places where they are not easily accessible. So when we're able to get access to them and refer them for treatment, if we realize that, let's say someone is HIV positive, we realize that the person will be telling you that the first facility you referred into for treatment is too far and it cannot go. And because of this, we have to also incorporate something called a company referral fund for them. But most times when they go for a time, when they have the fund, when they go for a time to access treatment, you realize that though they are supposed to be going on a monthly basis to access treatment, but once they've gone once, they will be discouraged from going again because they don't have the money to go, and the places where they're going to get treatment is also far. Then, because of the pilot project we are doing on the needle and syringe programs, you know that if you are engaging in something like pilot or whichever project at all, if there is no proper data documentation, reporting template strictly adhered to, it will amount to nothing because there will not be evidences to show for what has been done. So we do have issues with our trained injecting drug user peers reporting because many suffer from withdrawal symptoms too among them. And because of suffering from withdrawal symptoms, it is very difficult for them to fill papers. Or those from these people. So this makes the work very, very difficult. In fact, sometimes some days or after a review meeting, and all they'll just be able to do is to talk verbally a little, not really providing the written or documented data as they're supposed to provide due to the withdrawal symptoms and the tediousness causes them when it comes to reporting what they've done. Then over the months, we've been able to get different types of foods, like use 5 needles and syringe. But because of the how we're trying to prevent and how much we are trying to prevent them from overdosing, we make sure that the needles and syringe we have available for them are either 1 meal or 2 meals, so that at the time they will not be using excess. You understand? They will not be using excess. Now, provided some of these needles to be either detachable or fixed for them. So some of them who are living in far places who don't usually come around to get their needles, provide them with one that they'll be able to make better use of with the water for injection too that they use. And what has been able to help us so far, though Nigeria being a country where drug users are prejudiced against, is advocacy. Advocacy. And it shouldn't just be advocacy for advocacy's sake. It should be advocacy to the community level, not just looking at those people with names, not just saying, oh, we're going to meet with the governor, we're going to meet with the key religious leaders in the society. We look at having those in the enclaves where the drug user communities are domiciled, such that when we have any intervention to do there, once we consult these people, they'll be able to help us to reach them because they are high influence community leaders among these people. So these are the set of people that made our work easy. Then we also target influencers too in the communities, because apart from meeting with the big name stakeholders, so to say, there are some influencers in communities who may just be that baba with a shop next door, or that woman selling, who is a petty trader next door, who can influence these people to come out to have access to services that we are rendering them. So we also target this group of people so that we're able to reach the right population that we intend reaching with the harm reduction, both information and intervention that we're passing across to them. So yeah, that's how it has been so far. And from your presentation, Róisín, you mentioned 546,000 drug users living with HIV in sub-Saharan Africa, according to your last presentation. I can say I agree with that 100%. In fact, I would say there are more that are yet to be found. Because when these surveys were carried out, you realize that they were not as extensive as they're supposed to be. It's just among some population, not really among the general population, to be able to really know the number. These were just samples, because I was privileged to also participate in the survey too, in which we were able to say, oh, we have 14,000 plus drug users in a particular state in Nigeria. But in the course of this project implementation, we realized that we have far more than this, which shows that the sub-Saharan African region needs more and more of surveys, more and more of information on drugs, so that we'll be able to know the actual number of people that are drug users, and of these drug users, how many of them are injecting drug users, and be able to know how well we can intervene, the kind of intervention they will need. Because presently in the continent, in fact, let me say presently in the country, drug use is, I would say, is an epidemic now. Though the government says they banned it, though they say they are arresting drug users, but every day we get videos of young people overdosing on different types of drugs. So if there are no proper intervention for this set of people, we keep having casualties by the day. And the more casualties we have, the more unhealthy people we have, the more unproductive people we have, and the weakened a society also becomes. So this is just my submission. That's just a little of the presentation for now. So I don't know if there is any question or anything I may be asked.
Thank you so much for your presentation. It has been really, really informative and helpful. And I'm sure you can answer any of the questions far better than I can. So if anyone would like to ask any questions, please do. You can do so in the chat and I'll read it out, or feel free to unmute and ask now. You can also do the raise the hand option as well if you can find it.
Yes, Róisín, can I just want to ask a quick question, quick.
Please go ahead.
Okay.
Yeah, well, thank you for the presentation. And I think I just got two questions. And contextually speaking, is in between like, let's say Liberia, let's say Nigeria, Liberia. Like you just, in your conversation, drug use is strictly illegal in Nigeria. Likewise, Liberia. It's true.
Exactly.
And your engagement with people who inject and use drug, no, is very accomplishing. It's so much, applauding, to have such a young person, because it's not easy, like you just said. You would not understand people who use drug unless the people who use it with themselves, because like half of the expert and consortium on harm reduction people, like for me, I've known like almost like five. Half of them were people who use substance. Like some of them, they take Halloween with drug users. They know that, some of them have been people. So like your person was right. So my question is like, people who inject drugs, we don't already find them in Liberia, and people who inject drugs is only used there in Nigeria. So like, and we understand drug use is strictly illegal. So in the situation of like you conducting HIV testing centers is good, or is it in like, is it in line with the law of the government, because you say it's strictly illegal? So like if you are probably conducting maybe like needles and syringes exchange for people who use substances on the governmental level in Nigeria, how does maybe they see it? Because, and one of the things you say, you always start from the community, and so like looking at that, like you trying to reduce the risks, the minimization, harm reduction, all that. So how you guys look at that from a perspective where you guys using a community-based approach with your harm reduction policy, like in Nigeria, PRWDs. So how it's like on the governmental side, and also looking at the the policy level. Traffic don't need these people. They don't want to. So like the concept is, how does harm reduction to support drug policy reform, something like that? That's my last question. How does it work? Because when the policy is not in actor, CSO trying to do this work, government is not supporting CSO with the idea, like you have a challenge, you just said it. Police always hunt drug users, brutality against them. They don't even concern about the medical health and stuff like that. Even that, looking at the RDBS report, I try to compare Nigeria and Liberia. I think it's almost like the same. So I just want you to balance that question for me to get a clear picture of how it's like. Thanks so much. That's my question, I think.
Yeah. All right. Thank you very much. I think I should quickly answer. Your questions are two. The first one is as regards government policy and the activity carry out. Yeah, it is true that drug use is illegal in Nigeria. Strictly illegal. They are arrested, they are prosecuted. But government, those in government, somehow they know that intervention for drug users is inevitable. And because of the continent we are in, we tend to look at things more from religious and moral perspective than the reality of what we have on ground. So we realize that most politicians we have in the country, they look at things from this moral and religious perspective. And because they want votes from people, they don't want to say things or do things that their co-politicians will use against them. For example, no politician will want to come out and say, oh, I'm supporting drug users. It will be very easy for them to be defeated by their opponents in the coming election because they'll be like, oh, this is the politician that is encouraging our children or our youth to go into drugs. But we realize that policymakers in Nigeria, and our government agencies too, the government agents, many of them are aware of the situation on ground. So there may be no law to back it up legally, but individually, they render their support. And with the help of different international bodies we have, who have always been pushing our governments have been moved to just be like, okay, let's see, let's do something. Probably if we try this, it is going to work. Most times at the national level, the Inspector General of Police, the President, and some others at the end of affairs, they are aware of what is going on at the community level. It is just not in the Constitution that drug use is legal. But somehow, individually, these people are rendering their support so far. Because whenever we have issues at the community level, even police arrest at the community level, and we'll put costs through to these people at the national level, they're always ready to help. And one thing they keep telling us, especially the bodies fighting against drug use in Nigeria, is that they are not targeting petty drug users anymore. That it is the drug suppliers and dealers that are really their targets. That they even have rehabs. The Nigerian Drug Law Enforcement Agency, they told us that they even have a rehabilitation center for drug users in their respective offices in different states we have in the country. So you realize that many who even engage in the arrest of petty drug users, young guys using drugs and all, are not doing it as the government are directed them to do. They are just doing it for their own purse alone, just to extort these people and make money from them and extort them. So in terms of the illegality of drug use in Nigeria and government policy, yeah, I can say, though the government policy does not say this is legal in the country, but the policymakers have information and somehow they are supporting it. In fact, let me set an experience to you. There was a time during an advocacy meeting, I talked to a lawmaker about why it needs to help us with harm reduction information more, sponsor bills in communities and all. And what he said was, Obayemi, I understand you very well. I understand the concept of harm reduction. I understand that we need to intervene. But tell me how I'm going to go back to my community and explain all of these things you've told me to that woman who is a petty trader by the roadside, that we have to do this for drug users. So you understand that this, the scope, or let me say the policy, the legality in Africa and so on, if you work more, if you do more advocacy and stakeholders meeting with your law enforcement agents and your policy makers, you realize that somehow they render their support. So I think that has also answered my question in terms of the policy level you talked about. It is not going to be a one-day thing. We're going to say, oh, let's legalize this in the continent. It's going to be gradual. And it is when we do it from the communities, little by little, we realize that, look, this has to work. We need to have a policy in place to support drug users in our region.
Yes, it's well understood. Thank you. Thank you. It's well understood. Thank you so much.
Thank you so much for that in-depth response. It was really I think it's one of the kind of more pertinent aspects as well, because I think the biggest barrier that always comes up with harm reduction is the legality of it. But thank you so much. I think we are beginning to run short on time because we only have 10 minutes left, I believe.
Wow.
But what I'm going to do is move on to Yusuff's presentation. But if anyone has any questions in the chat, perhaps Obayemi, would you be able to respond to them there, or maybe I can forward them to you afterwards as well?
Yeah, you can forward it to me afterwards.
Great, thanks so much. All right, Yusuff, are you there? And would you like to go ahead?
Hello, everyone. Thank you, Róisín, and thank you so much, Mr. Obayemi, for that wonderful presentation. In Africa, we know that for basically our drug education focus more on abstinence. Don't do drugs, don't use drugs, don't do this, don't do that. But over the years, we realized that this approach is not working. In fact, drug use in Africa is increasing. And I think most of our stakeholders are getting to know this, that this approach is not working. So for when we talk about harm reduction in Africa context, I know it's going to be very difficult in terms of implementation, as you can see from what Mr. Obayemi said earlier on. So basically, for us to be able to actually implement harm reduction in Africa, the first thing we have to do is mind reorientation. The young people you have to engage young people, you have to engage more stakeholders, and we also have to look for a way to ensure that the generation of the next generation of the young leaders has to be well informed, educated about what harm reduction is all about. Because if we look at the generations that are actually against harm reduction in Africa, they are actually the older generation. Because what they believe in is that, okay, if you use drug, if you condone the use of drug and don't actually negate the use of drug, then we have more people using drug. Because that's one of the questions that keeps coming. Won't harm reduction increase drug use? But science is telling us that it's not increasing drug use, but even people that are graduated in science, some of them still believe that, okay, why is this a drug? But evidence over time have shown that harm reduction doesn't increase drug use. The aim or the primary target of harm reduction is to respect each and every one of the and also to protect public health. Because over time, let me for this, let me use people who inject drugs. People who inject drugs, if you don't provide harm reduction services for them, what will happen at the end of the day is that they tend to use the drug in slums and get to use the drug in dangerous ways, including sharing of needles. These people, they have wives, they have children. Some of them even have concubines that they go to have sex with unprotected cells. And these people, again, in a way, we can't say because we know that, okay, these people, they are using drugs, we have to negate them, we have to leave them. They will always come back to us. They are part of us. So it's not a matter of you just engaging some group of people, talk to them about this. We have to make sure that people are actually aware of the public health implication of neglecting people who use drugs. These are one of the things that we need to focus on when we are educating people. I leave someone that is injecting drug, keep injecting drug in slums. They will essentially do in slums and we come back and have sex with people, and those people will also have another sex with another group of people. So all these things keep increasing the prevalence and the incidence of HIV in Africa. And in Africa, we can't say we actually know the total number of people who use drugs, or the number of people who inject drugs. Because it's only people that we can see that we are actually giving the estimate. There are far more than that. But because of the social cultural issues and the social inequalities that we have in the Africa setting, actually make it more difficult to get to reach these people. So as young people, as an advocate, we need to keep telling people, we need to keep reorientating people, we need to keep doing our best to make sure that people actually understand what harm reduction stands for. It's not about you encourage drug use, it's about protecting public health. There's this issue also coming up with tobacco, use of smoking of cigarettes and blah 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 and all. We know that we can't stop people from using cigarettes. We can't stop people from smoking. Some people are already addicted. Some people can't quit cold turkey. It's very hard to due to addiction to nicotine. But over time, we notice that, okay, if we actually want to leave this group of people to keep smoking, and smoking has been shown to be one of the leading facilitator for non-communicable disease. So if we leave these people to keep smoking without anything to actually help them, then we're actually causing more harm to them. This brings about the concept of what's also as tobacco harm reduction. Over time, when we talk about harm reduction, most of our settings, we tend to neglect this part. Tobacco harm reduction is also another thing that is also coming up and is growing really fast. Because we can't say people that are actually smoking to keep smoking. We also have to help them. They are part of us. So that's why we have some options, some alternatives that can also be used to actually reduce the harm from smoking. But this has also come with a lot of challenges on the African continent and even worldwide, as regards the use of e-cigarettes, vaping, use of snus. But then it has been shown, and people that actually use this product are not engaged, because many people that use e-cigarettes, people that are usually using it, tends to give positive testimony about how this product is actually helping them to quit smoking. But then people that are actually at the front line are people who don't use this, who don't smoke, people that don't use any form of drugs. They are the ones actually determine the fate of people who use drugs. So it's another thing that we have to actually look at. It's important that we actually engage more harm reduction. Another thing in Africa is about our curriculum, healthcare professionals. So many don't even know what harm reduction is all about. You don't know kind of advice you can give to patients that have been having difficulty in stopping drug use. So this is the kind of thing that we have to keep engaging stakeholders and our young leaders on, because we are the leaders of today, and of course, most of us will still be leaders of tomorrow. So we have to be the one that will continue the discussion, and hopefully in the future we are going to have a significant impact. So throughout my stay in pharmacy school, I've never been taught anything on harm reduction. And most healthcare professionals in Africa, you don't really know what harm reduction is all about, unless one is curious to actually learn. So, and the so-called rehabilitation services that is available in Africa is judgmental, and people that are actually involved in these services actually force drug users or people who use drugs to get the service. That's it against the principle of harm reduction. So all these things, people that actually engage in these programs, some of them are not equipped with the right knowledge of what harm reduction is all about, on how to even engage with people who use drugs. Why will you force me to quit drug use? Is that the best approach? Is that the best way? And this is the that is common in Africa. I think incarcerate people, put them in prison, and they tend to even use drug when they're even in the prison. So I was checking through a study, and I know even in prisons, the harm reduction services in prisons across Africa is not to write anything about, because most people believe that if you actually engage people to use drugs safely through the principle of harm reduction, then you are condoning drug use. This is wrong, and we should try as much as possible as an advocacy group to actually keep educating people, keep giving them the right information. So I'm optimistic that the future generation to come, we have much more to offer to public health and to protect everyone, including the underrepresented and the marginalized community. This is just what I have to say about harm reduction. So as an advocacy, don't let us forget this. We are in the best position to keep engaging stakeholders, to keep speaking, and as time goes on, we're going to see a positive impact. Thank you so much for following.
Thank you so much, and thank you for such a fantastic presentation. I will note that we are a bit over time, but we do have some questions. So Yusuff, if you're happy to stay to answer maybe one or two questions before we keep going, or before you get going, that would be great. But if not, don't worry about it. But just for anyone who needs to run off now as well, don't worry, we're recording this session and we'll put it up on YouTube next week. So you'll also have access to it. But Leonard K I've just asked you to unmute. So if you raised your hand, I hope that was for a question. Please go ahead.
All right. I think this is not a question. It's a little contribution. I'm speaking from SSDP Ghana. And we are happy for this wonderful presentation. But one thing about Yusuff is that Yusuff notes that Africa is a whole continent, and countries are doing all that they could to make harm reduction one of the best. In my country, Ghana is doing very, very well. If it comes to issues about harm reductions, we are doing very well. Even there's a lot of offspring of private rehabilitation centers that are helping drug addicts a lot. And the good thing is that my country has a policy now, and we are hoping that it will be signed into a law very soon. It is called the Mental Health Bill. And we are all hoping that this mental health bill will come so as it will come and address issues about drug users, this mental health issues, a whole lot of things, decriminalizing drugs and other things. So yes, we know it's not an easy stuff. We are all starting something. We are hoping that we get there soon. But what we should do is that we should at least pressure organizations that can go, like our main focus is to pressure so as these policies will work very well to better help people, the cause that we are all fighting for. So I think even if in your country like Nigeria, they don't, pharmacists, you don't know anything about health bill and other things. I think this is why as SSDP, believers, we think there should be policies where we should bring them out to channel them through policymakers, so as we see how best we can get very good policy for harm reduction. Because irrespective of whatever is happening, drug users will be there, abusers of drugs will be there, but we should at least see how best we can reduce all these things. And we hope very soon. I'm praying that after this our election in Ghana and everything goes on well, the mental health bill will come, and if it comes into full force, many politicians are not liking the bill because there's a lot that the country have to spend on that bill to help in the mental health. But we hope we'll get somewhere. There's a little that I would like to add to what Yusuff just said.
Thank you so much for that input. That was great. Yusuff, please go ahead.
Yeah, thank you so much for that contribution. Why I'm actually using Africa, I know some African countries are actually doing well in terms of harm reduction. Nigeria, Ghana is coming up. But if we actually take out of the 54 countries we have in Africa, I'm so sure that more than 80% are not doing well. That's why I'm using Africa over and over again in my discussion. So I know some African countries are actually coming up when it comes to harm reduction, and we need to keep advocating. We need to keep pushing. I know that one day things will get better, unless when, especially when the younger generation are actually equipped with the right knowledge and skills as regards harm reduction. I'm so certain that generations to come will actually make more meaningful impact on the African continent as regards to harm reduction. Thank you so much for that contribution.
Thanks so much. Our next question, excuse me for the poor pronunciation of this name, but Hasumi Okpanachi. Sorry. I've asked you to unmute there, so if you want to unmute and ask your question.
Okay, good evening, everyone, and greeting to everybody. Yeah. My contribution is, first of all, I would like to appreciate all the speakers. You all have done justice to the topic, and I appreciate that. The issue of harm reduction in Nigeria is actually gaining ground. Like, I am a medical student. When I was doing my psychiatric posting, it's one of our professors, TL Sheikh. They are one of the pioneer people that are advocating mental health bill in Nigeria. There is mental health bill in Nigeria also that they are pushing, that they make sure it goes through also. And he also always emphasized on harm reduction. Like he used to tell us that one of the treatments for craving, as in for a drug addict who is craving, that is to give him more drugs. That one of the most important things is that you have to prioritize the life first. You are not in a bid to stop somebody from taking drugs and you end up losing that person. And so because sometimes some of these people that are addicted, by the time you deprive them of these drugs, and because sometimes some of these so-called rehabilitation centers, what they do is just to keep them away from accessing the drug and all those things. And some of the withdrawal syndrome that will set in might even end up killing them. So harm reduction is actually whether for every change there is always a resistance, and what we are seeing now is that resistance to that initial changes. And with time, as we keep pushing, even those that are uneducated, those that are not enlightened, with time also they will get to understand the importance of harm reduction. So I want to say kudos to SSDP and all those that are advocating harm reduction. Thank you very much. And that's all I have to say.
Yeah, thank you so much for that beautiful contribution.
Apologies, sorry, I was away from the mic. Is there anything else you want to add to that one, or shall we move on to our next section or our next question?
Well, I'm just appreciating for that wonderful contribution. Can move on to the next question.
Awesome. Our next question is from Isaac. If you'd like to unmute, please ask your question there.
All right. Good evening, everyone. Thank you, Róisín, for your initial presentation, and Mr. Obayemi and then Mr. Yusuff. Thank you so much for your presentation. They were really enlightening. I just want to make some comment, then ask a question. According to the policy and law of the National Drug Law Enforcement Agency in Nigeria, after I personally review it with some of my colleagues at SSDP, University of Calabar, we got to understand that the policy does not differentiate between people who use drug and people who do drug business, like sell drugs or traffic drugs. And their policy just, so far you are in possession of any drug, any illicit drug, you have to be arrested, persecuted, and melted any kind of judgments they want to give to you. So I want to ask, how can this be addressed? Because the policy does not differentiate between people who use drugs and people who traffic drugs. So how can we address this? And another thing I want to ask is that when we look at the Nigeria health sector, our government did not really give more attention to it, and then they are not seeing substance abuse or substance use as an health problem. So how can we advocate more for substance use to be seen as an health problem, and then probably it can gain the proper attention it needs to gain? So those are my questions.
Thank you so much for that question, Isaac. About the policy, what you can push for is reform, policy reform. And how can we go about this? We can't do this if we are not in position of power, or we can't do this if we don't have that, we are not in authority to do that. But we have to actually increase political will. So how can we do this? Is about targeted advocacy. We can try to actually engage more people that are in power about this. We won't stop, because it's when we stop doing this that everything just ends. When we keep pushing and when we keep engaging in grassroots reform about what harm reduction is all about. So it's very easy for us to actually catch the bulk of it and be able to actually change this policy. So policy reform is not something that is very easy, as you all know, because this has been in their mode of operation and all. But today, tomorrow, I can become the NDLEA leader. Then I have that, because I'm grounded and I have solid understanding of what harm reduction is all about, then I can push for policy reforms. That's what I'm saying. What we need to focus on is engaging the grassroots, engaging the young people. So if we engage all these this group of people, it will be very easy in years to come to have these people in position of power to push for policy reform. As for now, we can keep engaging them, we can keep telling them, but then we can't force them. We can't force political will. It's only what they want to do that they will do. But tomorrow, you can become the leader. Then I can become the leader of ND because I'm grounded and I have a good understanding of what harm reduction is all about. It's very easy for me to actually do the policy reform and to engage the relevant stakeholder with my position. So it's all about we see advocating, keep engaging people. So as we keep doing this, in years to come, there's going to be a good outcome of what we are pushing for. So to your second question, basically it's still about advocacy. It's still about advocacy. It's about targeting the right people. It's about engaging the young people, exactly the young people, because We are the leader of today, we are the leader of tomorrow. Even if those people that are in power now are not ready to change, we can keep engaging the young people, we can keep engaging the grassroots community, and I'm sure we are going to see positive impact in years to come. So thank you for that question once again.
All right. Thank you so much. Thank you so much. Please, I have one last question to direct it. I want to direct this question to Róisín. Can you hear me?
Yeah, just I think Obayemi might have something to add just to the last point there. So
Okay,
maybe
okay.
we do that question after, if that's okay.
All right, fine.
Yeah, exactly. I just want to comment on the second question, Isaac's second question about drug use not being seen as an health issue by governments and policymakers in Nigeria. Well, with my experience so far, I realized that that is not totally true. But policymakers and governments and those in power shy away from issues related to drug because they believe it is capital intensive and there are more important, in quotes, more important things to do with money than pumping it on drug users. So if we as youths can keep engaging with international donors and making our government see reasons why they need to accept the ideology of these donors and what we want to do, I believe they will work more with us. For example, everything I narrated to you earlier that we do, no single penny of the Nigerian government is spent on this. The money comes from international donors. All the commodities we distribute, the needles, the syringe, the condom, even the salaries, the wages, the stipends of staffs, and everyone working on the project come from international donors. So once you can allay the fear of the Nigerian government, at least for now, that international donors are coming and they are ready to spend on this, I can assure you that they are ready to spend. I mean, they are ready to support. And on the NDLEA law that you mentioned earlier, that there is really no differentiation between someone in possession of drug and drug dealer. I had the opportunity of speaking with the commandant of the NDLEA in Oyo State. And from her, she is a lawyer by profession. And from her speech, she was able to make me understand that if all those who are caught in possession of drugs are to be arrested, the Nigerian prisons will not be enough to accommodate them all. That what they do is, when they arrest these people, when they get to their office, they're able to know who is a dealer, who is just a user. Then whoever is just a user, they have a rehab in their respective state offices too, where they try as much as possible to rehabilitate these ones. Either, in fact, what they focus on most is to make them stop drug use. So one can come in now in that you cannot force these people to stop drug use, but all you can do is assist them so that they do not harm themselves with drug use. So as Yusuff mentioned earlier, it still has to do with advocacy and policy. Thank you.
Thank you so much. Moranflu, did you have something to add there?
Hi everyone. I was going to buttress the points, the aspects of the aspect of the NDLEA Act. So the issue is because the NDLEA Act has not been reviewed in recent years, like over a decade now. So it's been difficult for the Nigerian government to actually have a law that is inclusive in regard to the West African region. But there is this part of the Nigerian government has been able to develop, that is the Nigerian National Drug Policy Master Plan. So it's been done every 4 years, and that's one of the things was to implement a new strategy that is a global method of addressing drug policy issues across the world. So the Nigerian government has been able to tap into some of these things from organizations like Global Commission on Drugs and the likes. But unfortunately, because the NDLA was built to be an enforcement agency, so it's been really difficult for the harm that deals with drug demand and reduction to really be effective. But one of the things we need to do, just like Yusuff said, is a constant knocking on the door, and that's advocacy. So we can really contribute our own quota by seeing how we can reach out to our legislators and people in corridors of power to see how we can influence decisions. So, but if we want to still continue maintaining this decision that NDLA does not treat users and dealers differently, we are not going to really get the results we want. We just have to have keep having our own documents, our own files, and the likes to see how we can implement this. In as much as NDLA Nigeria does not differentiate between criminals, between users and dealers, we have been able to also work with them to rehabilitate young people. We have been able to work with them to release people who were caught with little quantities of drugs. So that is to show that there's light at the end of the tunnel. So it's just more of constant advocacy and education and enlightenment. We can't also give what we don't have. So for us to be able to do most of these things, we need to also equip ourselves and empower ourselves with the right knowledge and information. And those are what we'll be needing on this street of power. So thank you. That was just my little contribution. But we can always it can't end today. We only continue discussing about them. Just like in Nigeria, also in Ghana, we have the issues of most of the rehabilitation centers in Ghana are privately owned. So that's another challenge also. We go to Liberia also. We have same issues, and most of, even the after war is still affecting a lot of people in Liberia, the Congos and the likes. So this topic itself, we might probably have a second, maybe a series 2 of the discussion. It's really a very long one. Thank you.
Yeah, definitely. I think we will definitely do follow-up session on this topic. Does anyone have any last comments on that point, or shall we move on to Isaac's next question? All right, Isaac, would you like to come through now?
All right. Thank you so much, Yusuff. Thank you so much, Mr. Obayemi and Mr. Moronfolu. Thank you so much. I really appreciate your answers to my question. So my last question is, over time, I've been engaging with some drug policy experts, and then Mr. Yusuff made mention of tobacco harm reduction the other time. And whenever I suggest tobacco harm reduction to drug policy experts, they tend not to associate with tobacco harm reduction. So I want to know, is there actually a toggle between tobacco and drug? And then is there a need for nicotine, what's classified as a drug, to sort this toggle? So those are my questions.
Okay, thank you for that question. Over time, many people that are in drug use space don't see, some of them don't see nicotine to be part of what they should advocate for. Even if you read about harm reduction over time, what you keep seeing is people who use drugs, people who get drugs, people who use cocaine, heroin. We won't see people talking more about nicotine. But now, tobacco harm reduction is a new concept, actually relatively new compared to the use of other drugs. So that's why you might find that significant difference. But anyone that actually believes in the principle of harm reduction, that understands the principle of harm reduction, we know that that also applies to the use of any drugs. So far, there's something that they can use to actually reduce the harm from the actual drug. This is what I'm saying. We all know that tobacco smoking, the harm from smoking actually comes from when you do the combustion, when there's combustion, when you light up. It's not actually from nicotine. From nicotine science, anyone that understands nicotine science, we know that the cardiovascular effect or any side effect that can actually have from the use of nicotine is just transient. Within a short period of time, it will wear away. But the major harm to smokers actually comes from the combustion, lighting of cigarettes. That's what generates the CO, the H2S, and other dangerous chemicals, the tar. So if we actually promote the use of safer alternatives, I mean, okay, this is primarily use of something that is less harmful compared to smoking. And we also give people the right to actually decide on what they want to use after we give them the clear information. Then why not embrace it? And over time, people that actually use harm reduction products like e-cigarettes, most times people they tend to actually have significant improvement in their health, and that's well documented. But because in the tobacco control community, there's a division between the use of between the use of e-cigarette and other harm reduction products and e-cigarette and cigarette use. Between the tobacco control experts, like within them, there's actually that division. And the reason is not far fetched. So some people believe that okay, nicotine is bad, nicotine is not good, and studies have shown this that this is actually effective. This is what is actually this. This is what is causing harm. If you look at the latest report by Public Health England, you will see that Public Health England keep advocating for tobacco harm reduction. A well-known public health organization keep advocating for it because this is science. It has been shown that the major harm comes from when you lighting up the cigarette, when you actually, or if you use nicotine in its pure form. Though we can't say there's not going to be any side effect. That's the principle here. We can't eliminate risk. We can only reduce risk. Harm reduction is not harm elimination. It's harm reduction, harm minimization. You know there's risk, little risk, but then there's still risk. So we still have to inform people, give them clear information. If you want to smoke, if you want to use harm reduction products, which one are you going to go for after giving them clear information? We say that nicotine is not the major thing today. Between cigarettes, smoking, and the usage of harm reduction products, which one are I going to recommend? I will actually tell people to go for harm reduction products. If you know you can't stop smoking, you know it's difficult for you to stop smoking. Often from harm reduction, it's about rights, it's about freedom to make that informed decision. So is this something that we keep pushing for as regards tobacco reduction? We are still not there yet. We still have to keep pushing. But anyone that understands the principle of harm reduction, we actually embrace tobacco harm reduction. So thank you for that question. I hope I'm able to do justice to your question, Isaac.
I will add as well that potentially one of the reasons why there's often a divide between tobacco harm reduction and other types of drug harm reduction is if you look at the history of tobacco compared to other drugs, it's quite different, particularly like the recent history, in the sense that tobacco was like a majorly capitalized on product, and it was, you know, celebrated in society, and it didn't become illegal when all other drugs became illegal. And it was like it's such a commonplace item. And even if you look like back 10, 15, 20, like every, you know, decade ago, you see more like such high rates of tobacco use. So I think people look at it quite differently when you look at like our traditionally illicit substances like cocaine or heroin or anything, because the histories are so uniquely different. And then alongside the histories being different, the amount of research that's gone into those are different, and the way governments have reacted. So I'd say that's probably why when going to discuss it with like, you know, drug policy reformers who might traditionally work in the areas of illicit drugs might be like a little, I don't know, anxious or confused or like hostile, or I don't know what the exact term is, but maybe that's where some of the division is coming from, you know?
Yeah, I get. Thank you so much. Thank you, Mr. Yusuff. Thank you, Róisín. Thank you.
All right. Well, thank you everyone for staying on so long. I know we are way over, but I think it has been such a engaging session. I've really enjoyed all of the questions and the presentations by our amazing speakers today. And it has been really engaging. We definitely will do a follow-up session similar to this with the second part. If you have any thoughts on what that session should look like, please send them into the SSDP Africa Network chat or message me privately, because I would love to develop another session along these lines, because it's been really good. We will be we'll be sharing this session has been recorded. We'll be sharing this hopefully next week, so you guys will have access to it. This presentation that I've used here, at the end you will find a series of resources that are quite helpful. I won't go through them in depth now, but you will find like a series of different ones that are like different resources from the Harm Reduction International Journal, from some of our allies, like the West African Drug Policy Network and IDPC. All of these are kind of specific to Sub-Saharan Africa or West Africa. So I've shared the link to this presentation in the chat, and you can find this again later. And I'll also share this in a follow-up email and in the SSDP Africa Network chat. So if you need any of these resources and you can't find them, send me a message, but they'll be everywhere. But yeah, I want to say thank you again to our fantastic speakers, and thank you to everyone who's attended today and for hanging on with us a little bit longer than expected. And I will hopefully see you guys all at this session next month.
Thank
All
you.
right.
Thank you so much, Róisín. Looking
Thank you
forward
so
to
much.
next month.
You
Good
really
job.
contributed so much to this session.
Send me hi to Louis.
I will.
Thank you, everyone. Bye.
Bro.
Bye.
Yeah. Later.
Yeah.
Thank you.
Bye, everyone. Thank you.
Take care.
Yeah, I hope
Bye.
to see all of you face to face Sunday.